Good afternoon, everyone. I would like to thank Dr. Ashish and Dr. Arun Singh for the invitation to come to this wonderful meeting. And Ashish asked me to talk about the basic principles of revision arthroplasty. So just briefly where I work in the Golden Jubilee Hospital. A few of the people who are on faculty work with us. This is in Glasgow. It's one of the biggest arthroplasty units in the UK. We do about 4,000 joint replacement, and we have a big multinational, multidisciplinary team, including consultant surgeons from India, Austria, Germany, UK and Scotland. You will probably know why you're revising the implant. If you know why you're revising it, then you have to remove the implant. First is adequate exposure. Use the most lateral scars. Standard approach with releasing the medial and lateral gutters, and it's important to release the quadriceps tendon from the femur. We talked about the quadriceps nip or tibial tuberosity or tibia crest osteotomies. I do not recommend the quad turn down because it has a lot of complications and fairly significant lack of extension. When you revise the implant, the first obviously is remove a polyethylene. Then you remove the femoral component. The green side shows the accessible part, which is normally the flange of the implant, and the medial side, which is easily accessible. And then you have problems when you try to access the lateral part of the femoral component, which can be very difficult, and it takes a lot of careful preparation. For this side, you can only use osteotomes. Removing the tibia sounds easy, but in revision surgery, nothing is easy. And if you take this simple slide, it shows you that the easiest access is the medial side, and the difficult access is the posterior and the posteromedial aspect of the tibia. The blue side is the tibia keel, and the big red dot in the back is something that we all want to avoid. You start your medial exposure on the tibia, which is easy, and if you want to continue from the medial side to the lateral aspect, then you're running into problems because you won't have access, or if you go too posteriorly, you will hit something that you want to avoid. So it's a very useful, simple trick. You do a fairly significant release, and you go with maximal external rotation on the tibia, and then you can avoid the popliteal branches, and you have access to the posterolateral aspect. How to balance a total knee replacement. The tibia cut normally is 90 degrees, mechanical to the mechanical axis, and most revision systems have 6 degrees fixed femoral angle for the mechanical and femoral anatomical axis. This technique, again from Kelly Vince, is fairly simple. 3 steps. You have to create a tibia platform. You have to stabilize the knee infection, and this is why it's important that you try to choose the biggest fitting femoral side. And if you don't use posterior augment on a tibia, on a femur, you probably undersize your femur, and you will end up with a flexion extension mismatch. Then you align your femoral rotation. You normally use a transepicondylar axis, or you can use a tibia as a platform. And then finally, establish the joint line on the knee side. The joint line is very important. If you don't establish the joint line, the knee function will be impaired. It can be very challenging in revisions, as the most often used is the medial femoral epicondyle. And you can see it's about 25-28 millimeter from the medial femoral epicondyle. Finally, you stabilize the knee in extension, and to achieve that you need to use distal femoral augments, and you must avoid hyperextension because this is one of the worst complications. Basically, as you could see from this table, the femur is the component out of the two which controls the soft tissues, both in extension and both the extension gap and the flexion gap. There was a lot of discussion today and yesterday about stems and fixations, and this is also a paper I would ask you and urge you to read. This is a 3-zones fixation concept from Lydia Morgan-Jones from Cardiff, from Wales, and it's basically a very simple and very efficient concept. You have zone 1, which is the joint surface, you have zone 2, which is the metaphysis, and you have zone 3, which is the diaphysial area. And to achieve a well-fixed implant, you need at least 2 zones out of 3, so the implant will be stable. How you can achieve that? For zone 2, you can use cement, you can use cones, you can use sleeves, depends on what's available. If you have a zone 3 problem, you can use either a press fit or a cemented component. Finally, the question is, does it matter if you're a high volume or a low volume surgeon? And this is something I would like to spend a few minutes. What you see here is a revision knee replacement map of Scotland, and the Scottish Arthroplasty Project is collecting data from every surgeon regarding the primary and revision activity. And now, if somebody is classified as a low-volume surgeon, either for primary or revision surgery, that surgeon is identified, and the surgeon will be asked why he's continuing to be a low-volume surgeon. Low-volume surgery for revision is 10 operations per year. So you can see this is the 2017 report from the Scottish Arthroplasty Project, and now there is a national drive to establish specialized high-volume revision centers which will have better outcomes and will be more effective for surgery. So at the end, just to summarize, I wanted to talk to you about basic principles of revision knee arthroplasty. You need to know why the implant failed. You need to know, and you have to practice, how to remove the implant safely. And finally, you need to know how to achieve a well-balanced and well-fixed revision knee arthroplasty. Thank you for your attention.